Okay, looks like we have a good group of people. Hello, everyone. Welcome to our October webinar for the UCSF Child and Adolescent Psychiatry Portal. Today, our topic is anxiety, diagnosis, and treatment. My name is Ho-Hui Eileen Wayne. I'm one of the child and adolescent psychiatrists staffing the CAP consult line. I also help to organize CAP CME and educational activities, along with my wonderful colleagues, Dr. Jeein, who cannot be here today, and Dr. Lauren Schumacher. Before we begin, I have a few housekeeping notes. Today's session will be recorded and it will be posted on our CAP website for future viewing. If you have any questions during the talk when the presenters are giving the lecturing part, please use the Q&A feature in the webinar. We will also try to save a few minutes for the live Q&A. For the interest of time, I'm going to go ahead and get introduction started. It is a pleasure today to have our experts, Dr. Jeein Yoon and Dr. Samantha Fordwood here. Dr. Fordwood is a clinical professor at UCSF, where she works with high-risk teens, young adults, and their parents. Dr. Fordwood's clinical and research experiences focused on evidence-based treatments for children and adolescents, including cognitive behavioral therapy, CBT, and dialectical behavioral therapy, DBT. Dr. Fordwood specializes in dialectical behavioral therapy and evidence-based treatment that addresses the wide range of emotional and behavioral issues and involves the practice of emotional regulation, dysregulation, distress tolerance, interpersonal effectiveness, and mindfulness skills. In addition to providing clinical services, she also supervises psychology and psychiatry trainees and teaches about DBT and related topics. Dr. Yoon is a child and adolescent psychiatrist in the Division of Child and Adolescent Psychiatry at UCSF Department of Psychiatry and Behavioral Sciences. Dr. Yoon is triple boarded in pediatrics, psychiatry, and child and adolescent psychiatry. Prior to joining the faculty at UCSF, she practiced as a general pediatrician for the underserved and high-risk population at St. Christopher's Hospital in Philadelphia. Her primary interest is in integrating behavioral health in primary care pediatrics. She's a clinical assistant professor and associate director for resource development for CAP. She also serves as a consultant for the CAP portal, and she provides clinical care in outpatient psychiatry clinics and psychiatry consultation in primary care pediatrics at UCSF Bennett Children's Hospital, Oakland. With all that information, Drs. Fordwood and Yoon, please take it away.
Thank you. And here are some information about disclosures. And our learning objectives for today are to identify and diagnose anxiety disorders in youth, to be able to explain cognitive and behavioral strategies to youth and to their parents, and to identify medication options for treating anxiety in youth. So first, we'll start off by talking about what is anxiety. And while fear is typically described as the emotional response to real or perceived imminent threat, anxiety is more future-oriented, and it's described as anticipation of future threat. And there's a fair amount of overlap between the two. And it's helpful for parents and kids to know that anxiety and fear have a purpose, that it's in our genes for a reason. It helps prepare us for danger. It helps prepare us and be ready for threats, and it keeps us safe. Anxiety has both cognitive and physical components. It tells us to avoid danger, and often the action urge is to run away. And anxiety is adaptive and effective up to a point. The goal is not to get rid of all anxiety, and I think that's really important for parents and kids who are struggling with anxiety to know. Next slide. So anxiety becomes problematic when it is long-lasting, when it doesn't fit the reality of the situation, and when it gets in the way of functioning. And so you can see here the medical definition where we're noticing physical signs, tension, sweating, pulse rate, when there's doubt about the reality and the nature of the threat. And then there's also doubt about one's capacity or ability to cope with the threat. Anxiety disorders happen when our alarm system, you can think of anxiety as our alarm system, is out of order or not working correctly. So an anxiety, as the alarm system, it sometimes will go off in an actual fire, and sometimes it's going to go off just because of a little bit of smoke from a birthday candle, or maybe there's something stuck in the toaster, or maybe there's just a little bit of dust there. So some of us have more sensitive alarms, so there can be a lot of false alarms. And it's really important to be able to know when anxiety fits the facts and when it doesn't. So anxiety disorders are happening when our alarm system is out of order, not working quite right. When someone is experiencing a clinical level of anxiety, their alarm system is too sensitive. It's detecting danger that isn't really there, or at least it's not the catastrophe that is indicated by the anxiety. The intensity of anxiety really depends on the discrepancy between the perception of the threat and the perception of one's ability to cope. The lower one's ability to cope and the higher the perception of the threat, the more anxious someone is. And this is really often the key treatment for anxiety, how to accurately identify the degree of danger while increasing skills and confidence in being able to use those skills. Next slide. So here we're looking at the prevalence rates for anxiety disorders in youth with generalized anxiety disorder, so kind of excessive worry and a lot of physical symptoms of worry about a wide range of things. Separation anxiety disorder, often separation from primary caregivers, which would be associated with a lot of anxiety. So that can get in the way of doing anything without your caregiver, going to school, social activities. Social anxiety disorder or social phobia, so a fear of embarrassment, a fear of being evaluated poorly in social situations. Specific phobias, panic disorder, which would be recurrent panic attacks, really characterized by a lot of physical symptoms that happen out of the blue. And we're also including obsessive compulsive disorder here, even though OCD is actually in the obsessive compulsive and related disorders section of the DSM. So this is more, goes along with body dysmorphia, hoarding disorder, and body focused repetitive behaviors. But there's really a key, anxiety is a key component in OCD. One thing to note is that rates of elevated anxiety in youth almost doubled from 2019 to 2020. So going from about 12% to over 20%. So about 1 in 5 youth were experiencing very high levels of anxiety during the first year of the COVID pandemic. You can think about this also in terms of the mental health crisis that we've been talking about for youth just in general. On October 11th, so 2 days ago, the United States Preventative Task Force officially approved the recommendation to screen for anxiety in all youth 8 and older. So actually, when we submitted these slides, it was still a draft, but that now has been officially approved. And the recommendation for depression is to screen in youth 12 and up. So primary care settings are really a key place for anxiety screenings. And it's likely one of the first places parents go when they have concerns about their kids and anxiety symptoms or other mental health symptoms. So here are some examples of screening tools that are readily available and pretty easy to administer. The SCARED is a screening tool for anxiety and related disorders in youth. And that would give information about several different anxiety disorders. It's 41 items. There's a parent version and a child version. The GAD-7 is for ages 11 and up, and it's only 7 questions, extremely quick and easy to administer. If, for any of you working with younger kids, you can take a look at the preschool anxiety scale, which is adapted from the Spence Children Anxiety Scale. And the common screening tool for OCD for youth would be the SciBox. So any of these can be used by anyone and can be a great place to start if you're trying to assess if someone's experiencing an elevated level of anxiety and potentially meeting criteria for an anxiety disorder. Next slide. So why diagnose an anxiety disorder? A key part would be to help kids get effective treatment sooner rather than later. If the sooner we start, the better we can intervene, the more quickly we can intervene, the less of a likelihood that the anxiety has created significant or longer lasting problems, either socially or at school. It can also help with an official diagnosis. It can help with services and support at the school. As a primary care provider, you could be involved with individual education plans or 504 plans, help with writing of accommodations for kids. And the goal of 504 plans and IEPs, that while they're not actual treatment plans, the accommodations help to kind of level the playing field. So it can allow an anxious child to be able to learn as their non-anxious peers do. It kind of helps get them started. And then over time, hopefully the accommodations can be adjusted as the anxiety is treated either with therapy or meds or a combination of the two. So depending on the anxiety, the accommodations would really vary, but these could be things like extended time for tests or for assignments, a reduced homework load, one-on-one discussions instead of class participation points. But these are things that you could be involved with, putting together and really supporting kids. And also a diagnosis can be really validating for youth and for their parents. They may have been struggling for a long time, not really understanding what's going on, and giving it a name, giving it a diagnosis can be very, very validating. Next slide. So once we've established that there is a problem with anxiety, we also want to think about how do we address it. And the purpose of this next section, we'll be talking about some CBT strategies. It's not that in a very short amount of time that you'd be able to actually conduct a full CBT protocol in your office, but more so that you can understand more about what CBT is and answer questions that parents and youth may have about it. So there's a lot, I'm going to go back for one more thing. So there's a lot of really great books that can be super helpful to youth and to their parents, and we have those listed at the end of this talk. And as a health provider, you can offer some information about both anxiety itself, so provide psychoeducation, and about CBT strategies. And one way to summarize these strategies is taking from Tamar Chansky's book, Freeing Your Child from Anxiety, is to shrink and approach. So we want to go back to, we were talking earlier about the perceived risk and perceived ability to cope. So really shrinking that risk through the cognitive strategies, and then approaching the feared task through behavioral strategies, because the more we avoid something that actually isn't dangerous, the more we stay scared of it, the more the anxiety grows. So you think of this as shrink and approach. Next slide, thank you. So CBT is an evidence-based treatment for anxiety disorders. It's really well established as an effective treatment for both adults and youth, and it's often considered the first treatment to try for anxiety. It is goal-focused and skills-based, and you can do CBT in an individual setting or in a group setting. And can be really helpful in a group setting to hear how other people like you are applying the skills and how they are benefiting from them. Course is typically around 12 sessions, maybe a little bit more, so you can really make a big difference in just a few months. You want to make sure, and you want to have parents make sure when they're looking for providers, that the therapy includes both the behavioral part, so exposure therapy, as well as the cognitive part, so cognitive restructuring. And we have some suggestions for how you can find some CBT therapists in the area a bit later on. Parent involvement. It's important for parents to know that they are going to be involved in CBT for their kids. The younger the kids are, the even more involvement from the parents. So parents are going to want to learn the CBT skills and strategies, be able to model them for their kids, to be able to help with the exposure exercises, and to provide reinforcement. Next slide. So there are three components of anxiety in the CBT model, and they all affect each other. So the cognitive component, so the perception of threat or coping, would be thoughts like, it's too scary, I can't do it. The physical component would be things like heart rate, breathing, digestion, muscle tension, headaches, etc. And then the behavioral component is the fight or flight response or freeze. And typically with anxiety, the action urge is to avoid the perceived threat. It's to run away. We can make changes in each of these areas to then change the experience of anxiety. While we can't simply just stop feeling an emotion, you can, not necessarily easily, but more readily, you can make changes to your thoughts, your actions, and your physical responses. And those in turn can then bring the anxiety down. Next slide. So now we'll take a look at how anxiety works. Remember, the purpose of anxiety or fear is to keep you safe. It's our alarm system. It says avoid danger. And fear or anxiety fits the facts when there is a real threat to your life, health, or well-being, or to that of someone you care about. If there is a real threat, then listen to the fear or anxiety and avoid the danger. However, when anxiety does not fit the facts because the perceived threat is not actually dangerous, then acting on the anxiety by avoiding is not effective, because then we avoid doing things that are actually, in fact, safe. The anxiety sticks around, it gets stronger, and it gets in the way of us living our lives. So that could be going to school, that could be doing certain activities, that could be hanging out with friends, and it really keeps us stuck. And I think if you click forward, we'll get more of the slide here. Great. And then one more click. Thank you. Perfect. So here's an example about feeling anxious about answering questions in class. So this could go along with social phobia. So the interpretation of the situation would include a lot of worry thoughts, like, what if I say something stupid? What if I blush or start crying? Everyone will think I'm an idiot. Everyone will laugh at me, and no one would want to be my friend. So this is going to then lead to feeling anxious physically, and it's also going to lead to feeling anxious emotionally. And you would have the strong urge to avoid speaking up in class, avoid doing anything. By acting on the avoidance and staying quiet when the teacher asks a question, you would get a sense of relief in the short term. And that relief just is such a powerful reinforcer to avoid speaking up in the future. So the cycle continues, making it harder and harder to participate in class discussions. And the more you avoid speaking up in class, you have less opportunity to actually prove the anxiety wrong, to prove that if you did say something, it probably, for the most part, can't guarantee it, but probably is going to be okay. Next slide, please. So now let's take a closer look at the worry thoughts that are setting off the anxiety alarm system. And for older kids, you could maybe tell them about the amygdala, which is like your brain's security system, great for real danger, not so helpful for everyday situations like taking a test or meeting new people. The goal here with cognitive strategies is to recognize the worry thoughts as worry thoughts and not facts, and then come up with more realistic thoughts. So we want to shrink, again, the perceived risk so that it is a more accurate reflection of reality. We want to learn that anxious thinking is usually distorted, exaggerated, or unreliable, that the worry is to be tested, not automatically trusted. So just because you think it doesn't mean it's true. When we label the worry or anxiety, we're going to label it as, like, depending on the child's age, you would change the language. So the worry bug or the worry brain or the protector brain. And by labeling it, you get a little bit of distance between you as a person and the anxiety as an emotion. This helps us see the worry thoughts as hypotheses to be tested, not as definitive answers. So asking questions like, well, what is your worry saying to you, to identify the thoughts that are coming from worry or anxiety? And then you can ask follow-up questions like, well, do you really think that's true? Why do you think that's true? Next, we want to identify what our thinking brain. So you've got your worry brain, and then you've got your thinking brain, or your wise mind, or the detective, or the fact checker. You want to identify what that has to say about the situation. And this is really using the skill of checking the facts. and being able to see the situation from another more fact-based perspective. So say something like, okay, so your worry is saying that everyone will laugh and point at you. Well, what do you really think will happen if you answer the teacher's question? And you can prompt with follow-up questions like, well, what has happened when other kids have answered questions in class? And what has happened before when you've answered a question in class? And help them check the facts by asking questions rather than just telling them. You can also remind them of previous times when they felt anxious about something and then discovered it was ended up being okay. Over time, then we can see that the worry is often the problem rather than the feared situation, whether that be returning to school, talking in class, going to a social event, or petting a dog. We want to teach that we can't stop worry thoughts from popping up. Thoughts are going to do that. They're going to come up. We can choose whether we want to believe the worry or not, and we don't have to react to false alarms. We can teach kids to recognize that their alarm system may be overly sensitive. So again, referring to Chansky's book, she talks about teaching kids to think twice, challenge the automatic worry thinking, and build in a more realistic reaction. So we can also think of this as two-track thinking. There's a worry track and a truth track. And we can learn that we have a choice in how we think about things. Next slide. So in CBT, we have a list of common thinking mistakes, and we want our emotions to fit the facts of reality, not to fit our mistaken or exaggerated interpretation of reality. So parents can teach youth about these. You can teach parents about these. So parents can help kids identify common tricks that worry might play. So all or nothing thinking. I always mess up when I talk in class, or I never have anyone to play with. You can ask, is it really always or never? Can you think of other times when that wasn't true? And you can help kids recognize that always and nevers are very rarely true. And you want to change this to sometimes or once in a while, like, well, sometimes I mess up when I talk in class, or sometimes I don't have anyone to play with at recess. And this helps reduce the perceived threat, and it's actually more realistic. Catastrophizing would be when, just an example of how worry thoughts are really good at predicting the worst case scenario. So identify the worry what ifs, and then check the facts to see how likely the catastrophe is. Just because something is possible, it doesn't mean that it is probable. You can label the future thoughts as catastrophizing or fortune telling and get some distance from them. Emotional reasoning, another example. This is when we think something must be dangerous because we feel scared. So because you feel a certain way, then it must be that way. So we want to remember that feeling is not fact. We have to check the facts and see what the detective or fact checker has to say. Next slide, please. So going back to the CBT model, there are also skills that we can use to address the physical symptoms of anxiety. And we can teach kids and their parents that when our internal security alarm system is activated, even when it's a false alarm, our bodies go into fight or flight mode and get physically ready for danger. So they might feel their heart beating faster, or they may feel out of breath. They may feel dizzy or trembly or get a headache. And it's important for kids to know that these physical sensations are just a part of the alarm response. And when it's a false alarm, there's nothing truly dangerous going on, even though it feels like there's something dangerous going on. So you can ask, where do you feel your worry? Where is worry hiding? And identify it as part of the anxiety reaction. And you don't need to listen to it because it may be a false alarm. When we're in a state of physiological arousal, we can't think clearly. And so we want to change our physiology by activating the parasympathetic nervous system and cooling off the fight-flight response. And this can help us think more accurately and take more effective action. So there's different ways we can change our breathing, using breathing from our diaphragm, using belly breathing. We want to focus on the long, slow exhale. Can do paced breathing, like box breathing. So for kids and teens and adults of all ages, there's different ways that we can work on changing our breathing and cooling down the fight-flight response. Progressive muscle relaxation is when you go through the whole body and you tighten and relax different muscle groups. Kids can listen to a recording of this. Parents can walk them through it. Ice diving is when we use temperature to activate the parasympathetic nervous system. So think this is the mammalian dive reflex. So dipping your face, this part of your face, in cold ice water can be very effective for high anxiety. And then exercise, getting active, also helpful for changing physiology in the moment. Next slide, please. So now we're going to talk about behavioral strategies, namely exposure. So using cognitive strategies, we first help kids, reduce or shrink the perceived threat by labeling worry thoughts and fact checking. Then we want to help kids approach the situation in small, manageable steps so they can build confidence and a sense of mastery. You can relate this approach strategy to how kids learn to do other things that at first may have seemed scary, like riding a bike or learning how to swim. You want to develop your exposure hierarchy so that you can approach in manageable steps, or you can call them courage challenges. You can rate steps with a fear thermometer on a 0 to 10 scale, and you start where it's difficult and still doable. So there's a relatively high likelihood of success and still challenging. Next slide, please. So here's an example of an exposure hierarchy for someone with separation anxiety, so particularly separating from mom. And you'd want to do exposure activities frequently and then repeat each step multiple times. Ideally, the anxiety rating would decrease for each step after doing it a few times, and then you can move up to the next step. You also want to include rewards along the way, so parents can add in rewards here. Keep in mind that anxiety may increase when you first start to approach, and it will go back down. If a step is too difficult, you want to modify it by changing the length of time, who the activity is with, the time of day, etc. And find something when, parents are going to want to find something to reinforce in each activity, shaping progress towards being apart from the parent step by step. Next slide, please. So exposure is really hard to do, and there's a lot of benefits of it. By approaching previously feared situations, kids get to actually experience that the situation is safe. They are not just being told that it is safe. They get to see it and feel it and experience it for themselves. They get additional evidence that their worry thoughts are wrong, thereby weakening the worry bug and strengthening their wise mind or their detective brain. They learn that even if anxiety goes up when they start to approach something, it will go back down, and that it gets lower each time they approach rather than avoid. They learn that they can tolerate uncertainty, and that their ability to handle unfamiliar situations is actually quite strong in many cases. They learn basically that they can cope. So the difference between the perceived threat and their perceived ability to cope becomes smaller and smaller, and the anxiety is reduced. So exposures are really not easy to do. When we're afraid of something, every fiber of your being is saying, avoid it, run away, don't do it. It can also be hard for parents to resist the urge to rescue their child when they see them getting more anxious. But escaping and avoiding situations just reinforces the message that the activity is dangerous and that the child can't cope. So it's really important for parents to not model anxious behavior and instead be empathetic, encouraging, and matter of fact about the activity. So saying something like, I know that worry is telling you this is really scary, and I know that you really want to do a sleepover one day. So let's keep going with this courage challenge for 5 more minutes, and I know you can do it. Next slide, please. So behaviors that are rewarded are likely to happen again. When addressing anxiety, it's important for parents to reward the approach behaviors, which are often really hard to do at first and may not be inherently rewarding for the person doing them. We want to reward all steps in the approaching direction using validation, praise, high fives, or things like tangible rewards like stickers or points they can save up for bigger rewards like ice cream parties or a movie or something they want to do. Avoiding feared situations is reinforced through negative reinforcement, because avoiding something stressful provides immediate relief. This increases future avoidance, and we can't prove the anxiety wrong. So relief is really, really powerful, but that's what maintains the anxiety, which is what we looked at when we looked at the cycle of anxiety. We really want to reward the behaviors you want to see more of, not the behaviors you want to see less of. So remind parents to be careful to not reward avoidance. You know, what kid wouldn't want to stay home instead of going to school if they can play video games, watch TV, or hang out with their parent doing fun things all day? So parents really want to keep that in mind. Next slide, please. So we want to seek professional help if the anxiety is intense, long-lasting, interfering with typical activities, and isn't getting better. So if parents are reading books, teens are reading books, they're trying to do things on their own and things are not improving, we'd want to consider therapy and or medication. So CBT is often the first recommended line of treatment. And as I said before, it can be individual, it can be skills groups. Parents would want to ask about the therapist's experience in CBT, making sure that there's exposure therapy and cognitive restructuring, and ask about the role of parents, because that's going to be key, especially with younger kiddos. Unfortunately, accessing CBT is maybe not very easy, particularly CBT using insurance or lower fees CBT. So good news is the CBT clinic in the Department of Psychiatry at UCSF is now open to referrals. It's been closed for new referrals, or at least for external referrals, for a really long time. So what would be recommended first would be a CBT group, and then individual CBT if needed. Parents can ask insurance companies for a list of CBT providers. There's low fee trainee CBT services at the UC Berkeley Clinic and Wright Institute. And there's also private practice providers in the area, just it's a lot more costly. And if therapy is not available or not sufficient, you'd want to consider medication, which Dr. Yoon will talk about now.
Thank you, Samantha. So I will move on to the medication category. So next slide, please. All right, so when do we want to consider medication management? Normally, combined CBT and SSRIs in most cases is recommended. We never want to recommend medication first without making sure that the child knows how to cope or learn those coping skills that are needed for anxiety management. But sometimes we get referrals from for families who already have a therapist, and the therapist notices that have been engaged in therapy for quite some time and have not seen much improvement, or the anxiety is too severe for these kids to actually engage in therapy and exposure techniques. Other cases, we see children who have anxiety and comorbid depression or other mental health disorders that would require medication management. And in certain cases, like during the pandemic is a great example, we've had really limited access to therapy or any type of mental health provider. And in certain cases with severe anxiety, if they can't access any services and medication might be helpful, that is one consideration to make. Next slide, please. So I wanted to talk a little bit about the CAMELS study. This is a landmark study for pediatric anxiety in the child and adolescent psychiatry world. This was conducted between 2002 to 2007. It was an NIMH funded randomized control trial across multiple sites. And what they did is they enrolled about close to 500 participants between age 7 and 17, and they randomized them into 4 different treatment groups. The first group was Zoloft and CBT combined. The second group was Zoloft only. The third group was doing 14 sessions of CBT. And the last group was given a placebo drug. So we'll move on to the next slide to look at the results of this study. Next slide, please. So when they looked at the 12-week outcomes, which was the initial CAMELS study, it showed that the combination group, which received Zoloft and CBT for the first 12 weeks, did better than placebo, of course, and then better than medication-only group, and it did better than the CBT group. They didn't really find a statistically significant difference when they compared the medication-only group to the CBT-only group. But in essence, it was pretty, they were confident to say that the combination group overall did better than the rest of the 3 groups, and maybe receiving any type of therapy might be better than placebo treatment. Next slide, please. So the authors moved on to do a follow-up long-term study from the initial CAMELS report. So that was called the CAMELS study, and they relaunched and followed up with these CAMELS study participants between 2011 to 2015. They were successful in re-enrolling about 300 of the initial CAMELS participants. And by that time, the average age range happened to be between 10 and 25 because these kids grew up, and same diagnostic criteria that they had to meet. And they kind of did a yearly follow-up during the study period to see how many of these kids still met criteria for these anxiety disorders, how many were in remission, how many just relapsed. So they collected all of these data points, and the results are on the next slide. So we'll move on to the next slide. So what is interesting is that the authors hypothesized that combination treatment group would do the best in terms of long-term remission. But if we look at figure 3, actually, the red bars are the CAMELS responders, and they happen to do overall better in terms of long-term remission status compared to the non-CAMELS responders. And when they did like a person-to-person comparison within the 4 years of follow-up, about 22% of the people enrolled were in remission status. About 30% remained chronically ill, meeting criteria for an anxiety disorder at any point during those 4 years. And about almost half of the study population happened to be relapsers. So that's one point that I wanted to highlight. We probably are under the impression that anxiety is a waxing and waning diagnosis, but for sure, almost half of these kids did relapse at some point. So they also looked at whether which group they were initially assigned to during the CAMELS study would be directly linked to outcomes at the follow-up study. What's interesting is that it didn't really predict which treatment group you were assigned to, didn't really predict long-term remission status. And what was interesting, the positive predictors for remission was actually if you had actually responded during the CAMELS treatment in the first 12 weeks, whether you were assigned to the combination group, the medication-only group, or CBT-only group, those people who did well during those first 12 weeks had a lower rate of chronic illness at follow-up. Also, other positive predictors are male gender, being young at the age of detection and intervention, better family functioning, better global functioning in general, and having few negative life events. And they also found that kids with a social anxiety disorder diagnosis did a little worse than the ones without. Next slide, please. Okay, so we're going to talk about some of the SSRIs that we most commonly use for anxiety treatment. This slide kind of shows the FDA approval for the medications we commonly use in treating anxiety, depression, and OCD. As you can see, the Prozac, the Lexapro, the Zoloft are probably the three common ones that you've mostly heard about. And for depression, we have the two that are approved, Prozac and Lexapro, each for age 8 and up and age 12 and up. For OCD, Zoloft is approved as young as age 6 and up, and Prozac is approved for age 7 and up. What's interesting is for GAD, Cymbalta or duloxetine is the only one that actually has an FDA approval, but many in real practice, we do not use duloxetine as first line. We tend to use one of the 3 SSRIs, which are fluoxetine, Lexapro, or Zoloft. And I can go into a little bit of data regarding that in the next slide. So this study was published in 2018 by Dr. Strand, comparing the SSRIs to SNRIs in treatment of anxiety disorders. So at week 2, they start showing a clinically significant improvement in terms of treatment of anxiety for both SSRIs and SNRIs. That clinical improvement is statistically significant even at week 12 for both. But as you can see in graph B, the SSRIs have a greater remission rate and magnitude of response compared to the SNRIs. They also did a comparison between a high-dose SSRI and a low-dose SSRI, and both are almost effective and statistically significant. They just found that the low-dose SSRI had a wider variance in terms of response rate. Next slide, please. So how do we start an SSRI? I would say we don't really have research much on the pediatric anxiety in terms of whether one SSRI is superior to another one. So we choose either a fluoxetine, sertraline, Lexapro, with the family's comfort level, side effect profiles, what we think might be more helpful for the patient situation, and start at a very low dose just to make sure that they're not going to run into any big adverse side effects. So for instance, fluoxetine, the starting dose can be started at 10 milligrams or so for like a full adult size teenager. Sertraline, we usually start at 25 milligrams, 25 for minors, and Lexapro anywhere between 5 and 10 milligrams. If I have a preteen or someone who's more sensitive to medication, a lot of somatic symptoms, I might even halve that dose for starters and bring them back in a week or two to just kind of monitor any side effects, if they're tolerating it okay, and if they are, would increase the dose to the next step. From there on, I would probably monitor every 2 to 4 weeks. If it's an acute situation, if they're in somewhat of a more stable situation, you could bring them back every month or 2 to monitor and titrate as needed by small increments. Now, if there's only a partial response or there's room for improvement in symptoms, you can definitely titrate at the next visit. As long as they tolerate without any side effects. If the side effects are really intolerable, we would have to think about switching to an alternate SSRI category. And at some point, if our patients are doing very well with remission and symptoms, they're functioning well in school and in family life, we can consider tapering off after a full 12 months or longer period of remission status. Next slide, please. So this is going over like the typical dosage range for each of our SSRI category drugs. I just want to point out that out of the 3, Prozac has the longest half-life. So sometimes that does work to the benefit of some of our teenagers who forget to take it or are resistant, or if you have suspicions that they might be non-adherent. So that might be one factor that I consider when I choose Prozac over the others, but all 3 are very good choices for depression and anxiety. Next slide, please. So when we are starting SSRIs, we definitely want to talk about the side effects. The most common ones we get complaints about are GI upset. So any abdominal pain, nausea, dyspepsia, sometimes diarrhea and headaches. Some kids do complain about feeling tired or with low energy, difficulty sleeping as well. And if that happens, I usually play around with the administration timing. So if they're having trouble with difficulty sleeping after starting the SSRI, I just have them take it in the morning. And if they're too tired all day long, I'll have them take it at bedtime. You also want to discuss the activation side of that profile. So there is a risk for increased like motor activity, restlessness, being fidgety, being more irritable or impulsive, having trouble with sleep. They might look a little bit more disinhibited, so to speak, lashing out, losing their filter. Sometimes for younger kids, it might look like they're having a paradoxical reaction on a benzo or a Benadryl. So I do warn them about it, but for families to take it with a grain of salt, know your child's baseline if they're already having emotional dysregulation or ADHD symptoms, that this would look 2, 3, 5 times worse than what your child is already like. And in terms of management for that, sometimes we can scale back on the dose a little bit and titrate more gradually, or if they really can't tolerate it, we would have to switch to an alternate category SSRI. Next slide, please. This is just for your information. I think I went over most of this, so I'm going to go to the next slide. And then in regards to the black box warning, I did want to make mention of that this is something all SSRIs that are used in youth under the age of 25 should be aware of. But one thing to point out is that the black box warning study was actually done in 2004 on a patient population with a primary diagnosis of depression. So they did see an increased risk of reports for suicidal ideation and self-harmful thoughts, but that didn't actually translate into completed suicidal acts or actual like detrimental harm. So that is one caveat. And when they actually stopped treating these children, there was more of an increased outcome in terms of like suicidal, like completed suicide. So that's one thing you want to like weigh the risks and benefits of treating. But there are some more reassuring studies that have come out in the past 5 years or so that the treatment emergent suicidal ideation does not happen when we treat anxiety disorders or OCD with SSRIs. So that may be a reassuring factors to discuss with families. Next slide, please. So one thing I wanted to talk about is just tiers of treatment, anxiety, depression, all of our mental health disorders. They're never one-dimensional. If you catch it early enough and intervene early enough, like a little bit of therapy or medication management might be enough. But like Samantha had mentioned earlier, we want to make sure that this child is being supported in their environment, whether that is in the school setting or at home in their social life. We've definitely seen children whose anxiety started off as small or struggling with like academic achievement that really grows bigger and bigger as they go into their teenage years. They start avoiding school, they give up on their academic work. And at that point, it might be a little bit more challenging to tackle. So we want to make sure that you are addressing the maladaptive coping skills in their environment, working with the schools, working with the parents and their environment. And then you also see kids who end up resorting to really maladaptive coping mechanism, barging into the substance use arena or self-harm with engaging in cutting because they have poor coping skills. And at that point, we would have to really implement intensive behavioral treatment strategies as well. Next slide. So if we don't see a good treatment response, we have to start thinking about whether the patient is ready to engage. Are they ready for change? Have they been actually taking their medications as prescribed? Are they actually attending therapy sessions? Are they implementing their coping skills that they have learned, or are they continuing to engage in these maladaptive coping mechanisms or engaging in substance use or self-harm? We also want to make sure that we are monitoring the medication and the therapy quite closely, and have we made it to an effective dose? Was this an adequate trial, or did the family and patient give up on it too soon? So those are all questions to think about if you're not getting a good treatment response. And in the end, if there's no improvement, we have to come back to the drawing board and think about, do we have the right diagnosis, and think about other differentials. Next slide, please. So the last couple of slides, we are sharing some resources for patients and families. On our CAP website at UCSF, we have a patient and family resources section, also a provider resource section where we list a lot of rating scales, book lists, other external websites that families can go to learn about anxiety. And also I wanted to point out one other website, which is the copingcapparents.com. The Coping Cap Manual is something that we use as a protocol for CBT in school-age children. And the website actually has a nice learning session for parents that they can engage via online. Okay, next slide, please. And we are also sharing a list of books for parents. Helping Your Anxious Child is a nice one. It will talk about how to model behavior as a parent and like stay away from enabling the anxiety, all of the coping strategies that you can probably implement with your child. And then next slide, please. And one nice book for children's in school age. This is like an illustrated chapter book for elementary school kids, what to do when you worry too much. Dodd and Huebner has many books in different anxiety and temper and nightmares. So this is a very nice one where the parents and children can work together and label their anxiety, identify coping skills, and it's a very helpful, a self-guided book. Okay, so I think the next slide is references, and thank you for attending. I think we'll be open for some questions at this point.
Yeah, thank you so much, Drs. Fordwood and Yoon, for the fantastic presentation.